Extended spectrum beta-lactamase bacteria, ESBL producing bacteria, can fool you, and wrong antibiotic choices can cost lives. Today I'm going to talk to you about the 5 important facts that you need to know that's going to help you in the management of these infections. Hi, my name is Dr. Ermias Graffi. I'm a board certified internist working as a hospitalist in the United States. I have a YouTube channel called Smarthospitalist. If you like practice changing updates and tips in hospital medicine, make sure to subscribe to the channel. I'm going to start this with a case. Your patient's urine culture grew E. coli. It's resistant to ceftriaxone and ciprofloxacin, but sensitive to cefepime, zosyn, ertapenem, meropenem, and bacterium. The patient appears sick with tachycardia and fever, nausea, and vomiting. She was empirically started on ceftriaxone before the urine culture resulted. What would be your best antibiotic choice for this patient right now? Cefepime, zosyn, that's piperacillin, tazobactam, ertapenem, meropenem, bacterium, just trimethoprim, sulfamethoxazole, or there's always the option of calling the ID physician on call and letting him or her worry about it, because this is beyond our pay grade, right? So think about this case while we continue our discussion about ESBL bacteria. First fact you need to know: ESBL is a resistance factor, it's not a virulence factor. ESBL producing bacteria are no more virulent than non-ESBL producing bacteria. They're just the same. The only difference is they are capable of inactivating most penicillins, cephalosporins, and aztreonams. ESBL bacteria can cause infections which range from colonization to mild infection to serious infection as any other bacteria. So do not be afraid that the patient has ESBL infection and they will have serious infections. And also, ESBL is targeting penicillins and cephalosporins and aztreonam, which means all other antibiotics which are non-beta-lactam are still active against ESBL bacteria. Second fact that you need to know about ESBL is ceftriaxone resistance is a proxy marker for ESBL bacteria. If a bacteria is resistant to ceftriaxone in vitro drugs and sensitivity studies, then for all practical purposes, it is considered as ESBL. Of course, there are other reasons why that bacteria could be resistant to ceftriaxone, but they are minor. Therefore, ceftriaxone resistance is equal to ESBL for management purposes. Well, there are certain gene expert biopanel assays which directly detect the gene sequence for the enzymes causing ESBL. And in fact, in the hospital, what I did my residency, they have this capacity. Therefore, what they do is when they inoculate the blood cultures with the first grows, they will do gram stain, and if whether it's a gram positive or gram negative growth, they will take a sample and run a whole assay of gene expert. It's really awesome. Then you can detect what kind of bacteria it is and what kind of resistance and virulence genes it has. It's really awesome. Before the culture growth, before you can identify the bacteria on the culture after 48 to 72 hours, within 24 hours, you'll have this capacity. Before you even know what kind of gram-negative bacteria it is, you will have the capacity to know that it is ASBL if you see that CTXM gene is detected in the sample. But this is not available in most centers, and the easiest fix is to use ceftriaxone resistance as a proxy marker for ESBL infections. Third fact that you need to know is zosyn and cefepime may not work despite in vitro sensitivity. The microbiology lab may give you a result which says that the bacteria is sensitive to cefepime and zosyn but resistant to ceftriaxone. Then you have to question. The bacteria is most likely not sensitive to zosyn and cefepime in real life because cefepime is a cephalosporin, just like ceftriaxone. So the ESBL would work on the same way it works on ceftriaxone. Zosyn sometimes could be a viable option because of the beta-lactamase inhibitor tazobactam, but this has been studied even in randomized controlled trials, and they found out that treating ESBL infections with zosyn was non-inferior, was inferior compared to treating them with carbapenems. So clinical efficacy is not that great, even if there is in vitro susceptibility to zosyn. So zosyn is not clinically safe. So it's better to avoid using zosyn as well. By zosyn, I mean piperacillin tazobactam. That's the most common brand name that we use here. But with this fourth fact you need to know is carbapenems are the drug of choice for serious ESBL infections. Well, this depends on how severe the infection is. There are these people who have simple cystitis from an ESBL infection, right? An ESBL bladder infection, no systemic features. These patients do not need to be treated with meropenem as long as you have good sensitivity data to either trimethoprim sulfamethoxazole, nitrofurantoin, fosfomycin, or the quinolones. You can use either of these medications to treat simple cystitis. For patients with complicated UTI with pyelonephritis, but who are not really sick, if quinolones are, if the bacteria is sensitive to quinolones, even if it's an ESBL bacteria, still can be, quinolones can be used for the treatment. For patients who have sepsis or septic shock or who are really critically ill, these patients need to be treated with carbapenems. And the choice of carbapenem for patients who are very sick, those patients with hypoalbuminemia, severe hypoalbuminemia, or in general clinically sick picture is meropenem. Of course, ertapenem is a good antibiotic. It can be dosed once daily, and it is a good choice for prolonged treatment. But in the first few days of patient treatment for a patient who is really sick, it might not be advisable because ertapenem usually binds to albumin. In patients who is hypoalbuminemia, it will be released into the free form. The free form will be released in the circulation and will be inactivated and metabolized. Therefore, you might not have good drug delivery. Well, there are other ways to circumvent this, like dosing ertapenem twice daily or using a higher dose like 1.5 grams a day. But again, meropenem seems to be the safer choice in these patients, so you need to the recommendations are meropenem. By the way, this talk is based on the IDSA guideline for management of for the management of drug-resistant gram-negative infections in 2024. That's what they recommend. So another way to approach this would be to start with carbapenem, with meropenem for a sick patient, and basically transition to ertapenem when a patient gets better. The fifth point that you need to know is oral step down is still possible. Even if the patient has ESBL infection, the whole course should not necessarily be IV. Based on the high availability and sustained serum concentration, oral trimethoprim sulfamethoxazole and fluoroquinolones can be used for step-down oral therapy given one, susceptibility to one of these agents is demonstrated, two, patient is hemodynamically stable, and reasonable source control has occurred, and concerns about insufficient intestinal absorption are not present. These are some criteria that needs to be fulfilled, but certainly and safely you can put your patient on these medications. Of course, you cannot use nitrofurantoin or fosfomycin for gram-negative bacteremia or complicated UTIs, and because they don't have good tissue availability. All right, so these are the 5 most important points that you need to know in the management of ESBL infections. Now, let me go back to the case and see if you have guessed the answer right. So the answer for this sick patient with ESBL E. coli in the urine, which is probably complicated pyelonephritis, is going to be Meropenem. This is because she appears sick with sepsis, most likely might have some hypoalbuminemia as well, because we know that albumin is a negative acute phase reactant, and it will be lower in patients who are really sick. So you would go with Meropenem for this patient. Of course, ertapenem would not be a wrong choice, but Meropenem would be the safer choice in this patient. But I have one more question for you before I finish the talk. If this patient was started on piperacillin tazobactam or cefepime to begin with and not ceftriaxone, but now you get this urine culture result, which grew E. coli, which is ESBL, but the patient is already improving on the first antibiotic, which is piperacillin tazobactam or cefepime, either of the two. Would you change the antibiotic to Meropenem, or would you just continue the cefepime or the piperacillin tazobactam? What are your thoughts? You can write down your answer, your thoughts on this in the comment section. Of course, there is no right or wrong answer on this one. It's opinion based. Let me know what you think about this in the comment section. With this, I will finish the talk. If you enjoyed this talk and the contents of my channel, please subscribe to the channel. It's Smarthospitalist. It might be useful for your practice. Thank you very much. See you on my next video.